Thanks for being here. Okay, welcome everybody. Thanks for being here. I'm Elson Burke. I am an assistant professor of OB-GYN at University of Washington in Seattle. Laura Mercer, do you want to just quickly say hi?
I'm Laura Mercer. I am an associate professor at the University of Arizona, Phoenix, and our third collaborator is Andrea Aguirre. She is at the University of Arizona, Tucson, as the clerkship director down there. And she unfortunately couldn't be here today.
We can go on to the next slide and I'll just go. We have no relevant CME related disclosures. My personal disclosure is that I am currently in a land where it's approximately 60 degrees colder than Amelia Island. We haven't had power all week and I am poaching Wi-Fi outside. So bear with me while I am bundled in my down coat and hat, being very creative with this adaptive learning. And I'm sorry that we all can't be together. And if my Wi-Fi peters out on me, Laura will continue on and forge forward. So thank you all. So no disclosures. Thinking about what we wanted to talk about and share with you and kind of think about as a group, we wanted to briefly talk about fixed and growth mindsets and start to really think about ways that we can grow and develop the growth mindset for our learners when we are working with them. We wanted to review the AAMC's entrustable professional activities and how we can adapt. Oh, Andrea's here. Can't get her in, sorry. Hopefully someone can do that. Review those activities and how we incorporate our feedback and assessments to adapt to these activities and also encourage a growth mindset among our learners. We wanted to discuss the experiences that we've had at our 3 different institutions on trying to create more on-the-fly and workplace-based assessments to see how that can improve the quality of the feedback that we're giving to our learners and their improvement. And then finally, kind of discuss some of the philosophical questions related to the use of formative feedback. So thinking through mindset, many of you as educators are probably very familiar with Dr. Dweck's book, Mindset. This was written a while back now, and many of us, I think my first experience with her work was really within parenting and how do I work to increase the growth mindset within my kids as a parent. But it is so adaptable and really relevant with our learners as well. So thinking about mindset, it's our established set of attitudes and beliefs that we hold about ourselves and others. And the idea that Carol and her team really came up with is this idea of fixed versus growth and how we can kind of separate that and then grow more of the growth mindset because of the benefits that come with that. Thinking through the fixed versus growth, I think one of the biggest challenges that I face in teaching both medical students and residents is that so much of what we've had to do to succeed in our education to get us to medical school and residency really falls into a fixed mindset. There are correct answers that we need to get on many, many, many standardized tests. And we are set up that we must be, we kind of have to like win and succeed. And when there's feedback, we feel pretty devastated that we didn't get the right score or didn't hit the bar in a certain way. And so there's so much training that's happened in kind of the education through high school and college that kind of sets us up to really struggle when we hit medical school and residency, and really would succeed so much more if we have a growth mindset and kind of can embrace challenges with a different mindset. So I love this graphic. This came from Dr. Ballantyne and building off of Dr. Dweck's work. But thinking about, when you have these different challenges we're facing, how, kind of how the fixed mindset differs from a growth mindset and how we kind of address this and kind of what we think about it. I think things to really think about is this open mindset of how we really, in a growth mindset, it is always what I do with the residents and students is I'm always like, blah, 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 I haven't, blah, blah, blah. And I'm like, yet, if you just add yet to any sentence where you're kind of saying, here are my challenges or my struggles, it shows that no, yeah, I haven't, I haven't opened the abdomen yet, but I'm really prepared and looking forward to doing my first fan and steal, or I am really looking forward to tying that perfect square knot with some more practice, or whatever it is. And so saying that these challenges are opportunities for learning and growth, rather than places where you may be getting feedback that's negative and kind of putting you down in roadblocks. I think you can all read the slide, the rest, but I really think that to truly achieve as learners, we need to embrace the idea of a growth mindset. And then really the challenge that we were facing when we talked about this session is, how do we embrace that and give feedback in a way that actually continues to facilitate the growth mindset?
So as we think about growth mindset, that could be an entire workshop in and of itself. In fact, we had hoped for it to be one that hopefully we'll pick up next year in FDS. But what we're going to hone in for this super brief presentation is really on the ability to use some performance-based feedback systems, which are sometimes called workplace-based assessments, or at my institution, we like to call them on-the-fly assessments, which fit perfectly with our theme of takeoff and the rockets and everything. But it's the idea that we're utilizing frequent assessments to really help our learners be a part of that continuous quality improvement. And this is something that we're seeing. Obviously, quality improvement and quality assurance is something we do in the clinical realm, but it's something that in the business realm has really been embraced from a standpoint of process improvement overall, where we're really trying to help our learners be able to plan what their next step is, what are they working on, do it, check in with themselves, how did it go, and then act. So it's this continuous loop of improvement. And I think it ties really well in with the AAMC's EPAs, which are the entrustable professional activities. We like to call them everyday physician activities, because they're the key activities that we do all the time as docs. And so AAMC has some great toolkits for those of us that are in the weeds looking at this. And if you want to look at them more, the AAMC has really outlined quite a bit. What we've done at several of the our 3 institutions is looked at these EPAs and tried to figure out ways that we can help our learners iteratively practice their, for example, EPA number 1, performing a history and performing an exam and gathering a history. And so as we look at each of these activities and breaking them down into their core elements, we can utilize the Ottawa or Chen scales. This is the Ottawa, which is what we use at the University of Arizona Phoenix, where we ask our faculty to reflect on their relationship with the learner during that interaction. And it's really intuitive. It's what we do all the time, particularly with residents, in terms of deciding how entrustable we think they are. We may not consciously think about it, but we have that gut instinct of like, I'm going to be standing right next to them, or I'm going to have them just watch this one. And so we've really mobilized that with our faculty to help bring our learners through that Ottawa scale. So with our limited time left, we wanted to give you a snapshot of what each of our institutions are doing for these workplace-based assessments to help with that iterative and continuous ongoing improvement. Dr. Burke, do you want to start with you, Deb?
So many of you are probably familiar with MedHub, and I think we tried multiple different, we tried several different systems prior to adopting the MedHub mobile app within our residency. I think one of the things that was really helpful, and Laura will touch on this too, is a QR reader. So at one point, each resident had a personalized QR code that linked to their personal evaluation page, and it was on the back of their ID. And so they could just come up to you at the end of a procedure or a patient encounter. And our medical students had this as well as our residents. and you could just scan that. But then the QR coders would fade because they were just these little pieces of paper, and it, kind of after a rotation or two, they weren't as readable and whatnot. And so we really thought that switching to the mobile app would be most beneficial, and that we all have our handheld computers with us on the regular, and the Wi-Fi in the hospital is great, so that's not a barrier, and we can just do these on the fly evaluations. So I have the desktop on the main graphic. You can see that I'm delinquent. I have 2 incomplete evaluations, a little embarrassed to have to show my dirty laundry to everybody. But so that's kind of those are where we see the assigned evaluations. I find that the desktop app for MedHub for doing on the fly is actually much more cumbersome. With the app, I can just go into my institution, and thanks, Elise, for the, the support. But I can go into the app, I can pick the resident, and then I can resident or medical student, and then I can pick kind of what aspect of am I wanting to complete, because we divide them up among both just the interaction with patients, as well as we have some procedural ones as well. And so is it just the basic history and physical with a medical student? Are we looking at certain procedural aspects that we're wanting to cover? And I can find that from a dropdown. I can scan for the learner's name. I can find the dropdown for the on the fly, and it all takes me about 10 seconds to initiate an on the fly evaluation. And the nice thing is that we are trying to get the community to kind of buy in to doing this with the resident. And at one point we were actually having residents pull it up on their own phones and hand their phones to the, and I keep saying residents, but medical students as well, but handing them to the proctor or to the faculty. We found the biggest issue there is the empowering of medical students to ask faculty for feedback in that way. It was a barrier. With the residents, it works well. They just hand me their phone and say, do this now. I was like, oh, right. And then when we're doing it together, we can actually provide comments more than just these dots that we're filling. So the dots are great. They get compiled through MedHub. Our admin has beautiful documentation that we go over that goes to our clerkship directors, as well as to the residency clinical competency committee. But the nice part is that we then start the conversation. And that was what was really missing, was how do we initiate the conversation with our learners about the feedback and really starting that feedback in real time. I think that's kind of the highlight there for me.
Hi, so at our institution, we actually have 2 forms of providing feedback for our students. One is College of Medicine for the entire college, and using those EPAs to actually provide some formative feedback for the students, where they each have an individualized QR code. And it's meant to be a pretty simple 2-minute in the moment kind of evaluation, where the student presents their QR code, says, I'd like to have this EPA analyzed, and then we go and do that. That's been harder to enact in reality. I think a lot of it is really getting the students to feel comfortable asking for feedback in this manner. But when it's actually done in the way it's meant to be done, it can be done in 2 minutes. It's in a format that is, pretty simple, and we can even dictate our comments into the device that we're using, so that the student, the evaluator, really has very few limitations to their ability to get it done. But we have found that the biggest issue has been time with our residents. And so, and I mean the residents as evaluators. So when those students find that they need help from the residents with these evaluations, there is a lot of pushback on that. But when we as attendings do it, the students feel like they get a lot of great feedback. This is 35% of the students' grade, and it's just they either do it or they don't. We call these the WBAs. We also provide for our specific clerkship, as part of their clinical grade, they are also provided with a link to a survey that actually goes over the core clinical competencies, and that's where we get a numerical grade for our students. So we have 2 forms of evaluating our students that are both electronic. I do think that this transition has been a little bit bumpy, but I think that the overall feedback we get from the students is that they really enjoy being able to get feedback in 2 forms.
So I wanted to highlight that what Andrea and her team are doing at the U of A Tucson is based in Qualtrics. So it's a very homegrown, easy to implement. It's actually where we in Phoenix started. And I really like the way that they have the QR code. And I snipped some of these out of their faculty development about like how to use a QR code for some of our colleagues that may not be familiar with that. In Phoenix, what we ultimately transitioned to with a lot of cheerleading from me is into using my tip report. And many of you may be familiar with my tip report from its residency origins, as we were looking at being able to provide direct, immediate workplace assessments for our residents in surgical procedures. And what we've done is partnered with the developers on the app side, the computer coders, and we've just expanded my tip report to be an application based. It also has a desktop version that allows us to put the forms that we're most interested in. So for a medical student, I don't need them to be proficient in performing a laparoscopic tubal sterilization, but I want to be able to still gather all of those little snapshots, all of those little pixels that are helping the student figure out where they are and what they need to be working on. I wanted to acknowledge Sarah's comment in the chat, which is, how do you get people to fill them out? It's like pulling teeth. Andrea mentioned, yeah, it's hard. It's hard for me too. So I don't want to pretend like we have all the answers, but I will mention that over the last probably 3 years that we've transitioned to this app-based ability for our faculty, including our residents as educators, to fill out these quick snapshots, I have done so much less nagging and so much less begging, and so much less of my time is spent pulling teeth to get these assessments turned in. So what I have on this snapshot is sort of the overall menu. I can toggle back and forth between the medical school and the residency. And we're at the medical school at the U of A Phoenix, we're using this for all of our learners, years 1 through 4, across all clerkships. Some of us use it more than others and in different ways. And we use both the EPAs, and then we've also put in, we call them the Prime Plus forms. It's basically the RIME format with a P for professionalism and a plus for what else should they be working on, what's the next step. And this allows me then to sit down with the learners at the mid-clerkship point and go through their Prime Plus forms, go through their EPAs, help them identify some goals for the remainder of the clerkship. So in our final couple of minutes, and we were hoping that we'd have a little bit of time for a little bit of discussion or just plant some seeds for you all to think about, is thinking about how you're using formative feedback at your institution right now. Is it all verbal? Is it written? How are you doing it? And what is the frequency? I've taken to asking for this formal written feedback to be done at least weekly, but I encourage it to be done daily if possible. And I think the goal with workplace-based assessments is that they be done even multiple times during the day as the students continue to do that PDSA iterative improvement. But where's that sweet spot? How do you balance assessment fatigue with ongoing formative feedback? Another question would be, should formative feedback influence summative feedback? And if so, how? And how overall can we encourage students to be vulnerable in their own honest reflection and assessment of themselves as they're seeking feedback, if they're worried that it might negatively impact their grade? And that's one place where I'm struggling a lot, is between that formative growth mindset and that, if at the end of the day I have to decide who gets honors and who gets passed, how do I keep those things separate enough that the learners are still comfortable being vulnerable? So Marianne, what do you think? Do we have a couple of minutes for comments?
Yes, you do.
All right.
I wanted to acknowledge the comment in the chat of, as we move to more pass-fail in all 4 years, there creates space for a growth mindset. When we are less striving for hitting a certain benchmark and quote winning an honors grade, then there is room to grow and room to be vulnerable with that, recognition of, I can be vulnerable and make mistakes and still pass and move on to success in the specialty that I'm choosing. I think also one thing that is unique, I I carry a mentorship role where I most work with the students through the preclinical years of 18 months or 3 terms. And everything there, it is feedback central. That's all we do. We spend one morning and one afternoon a week with these students in the hospital at the bedside teaching, as well as in small groups doing the foundations of clinical medicine. And the best part of my job there is that I am not responsible for grading them. I am just responsible for fueling them with as much feedback and reflection as I possibly can. And it just creates such a different space where students are willing to make mistakes and take risks and challenge themselves in ways that they're sometimes more timid to do when I then see them later on the Ob-Gyn clerkship. I see Dr. Everett has a question. I wanted to circle back to how do we get, I think it was Dr. Bittman's question on how do we get people to fill these out. I did invest about $50 in Starbucks cards at one point. And I did a little gentle competition among the residents and said whoever could fill out the most would get a $10 Starbucks card per rotation. And when we only have 8 rotations a year, or maybe I guess I invested $80, but it was something very minimal. And we saw, I should have actually studied it, but we saw a good uptick because most residents like a little friendly competition. And I guess it wasn't Starbucks. I did our local coffee shop that was close to our hospital. Dr. Everett, I saw you had your hand raised.
Yeah, we are obviously considering this, so kudos to all of you who have already taken this leap forward. I see a lot of you, I love the idea of having EPAs and Prime Plus, like doing it in multiple ways. And I see that you could have potentially multiple 3, 4, ways with that, but you want to be careful of burden. My question's pretty specific. So I saw on your form that you had EPA and you could check which one. But what's if you go to history, what are you using for the sort of, I don't know, I hate to call it a scale, but scale of behaviors? Are you taking that language directly from the EPA book? And how are you getting agreement from your group as to what language goes into what box, I guess?
That is it totally makes sense. And it's a great question. And if I had to restate your question, I would restate it as, how do you build your form so it is long enough that you get the data points you need, but short enough that it is minimally burdensome? And at our institution, we keep calling it a pilot because we keep changing things. But over the last 3 years, we've actually changed our EPA forms quite a bit. And we started with probably 10 to 15 had been our initial goal for each of the EPAs. And what we found was that the entrustability level it frequently correlated well with all of the other radial buttons, did it, not yet, that we had for the prompts coming out of the AAMC's grids. And so what we've actually gone to is boiling it down to 2 or 3 key things that we really just want to know if the students are doing for each one. And then we use that entrustability scale. We're doing a modified Ottawa, and then looking at the comments. And we found that that really has decrease the length of time that our faculty are spending doing each of the forms without really sacrificing any of the detail or the formative feedback that we were hoping to get. I hope that sort of addresses what you were getting at, Elise.
Yeah, it does. Thank you.
I think there was another comment from Dr. Gabor in the chat about when and if everything goes pass-fail for all 4 years. Will that help our students to be more open to constructive feedback?
I think that's a great comment. I will share, we all had our adaptations during the, immediate turnaround, our curriculum when COVID first hit. And one of the adaptations that we did is we made all of our clerkships pass-fail. And it was like a refreshing breath of wonderful fresh air like Alison is sitting in right now, because I no longer had students that were micro dissecting the feedback they were getting and asking for meetings with me because they wanted to make sure I knew the whole story behind whatever comment they got. It was really just that growth oriented, I want to get better. And it converted me entirely. And I'm a huge advocate for pass fail in the clerkships. I know it causes, there's other considerations on the residency side, but on the undergraduate side, I am a big disciple of the pass fail now.
And then
I
there's
see.
another comment about my tips report uploading to new innovations.
I actually don't know that answer if my tip report will talk, if you will, to other systems. It's a programming thing, and I'm just not sure if that already exists.
My understanding is that it doesn't, but
Yeah, I'm not sure. It does have its own dashboard, though, which is helpful for review. We do it with our residents as well as with our medical students. Great discussion, everyone. Okay.
great.
Should we transition to our other
Yeah.
folks?
Dr. Gabor, in your group, are you ready?
Yes, I can go ahead and share my screen. Hi, everyone. My name is Patrina LaFair. I'm a PGY2 at Northwell Hofstra's OB-GYN residency program. And I'm going to be talking today about virtual learning and assessing the impact and the learning that our learners are doing with Dr. Gabor.
You want me to upload it, Patrina?
I am struggling right now for some reason to share my screen. So if you could, Dr. Ward, that'd be great.
Got it. Now the phrase that pays is, can everybody see my screen? Okay, I'll mute myself, Patrina, you can start.
Okay. Okay, everyone. So it's not rocket science. Are your virtual learners actually learning? Something that we all are wondering when we're sitting there during didactics and during lectures and we're staring at a blank screen, wondering what's going on. Dr. Ward, I see you. Next slide. Thank you. We have no disclosures, nothing from our end. So just reviewing the pros and cons, all of us are living this right now, so I'm sure we have thought through the pros and cons multiple times, but just to reiterate, some of the pluses of virtual learning really revolve around its accessibility. There's no need to travel. It's easier to have a diverse set of speakers from all across the country and the world without having to actually get them out to your institution, which is cheaper. It allows for more a more breadth and variety of what we're seeing and what we're discussing, which is wonderful. Another advantage is that you can have these asynchronous lectures where you're giving a lecture where you're recording it with the intention to distribute later, or you're recording in advance to distribute later to learners. And then in terms of flexibility, there's tons of platforms. With COVID, everything has blown up in terms of virtual meeting space. So there's a lot of different options, a lot of different platforms to use. And you can really find one that works well for you and your learners. And there's minimal need to get dressed up. Next slide. Some of the cons. So one thing that makes virtual learning particularly challenging is that there is you lose the ability to use these tools you've built for years, which is really learning how to see our audience, read our audience, understand if they're taking anything in, if they're paying attention, if they got a point, if they didn't get a point by just reading their faces. And it's really difficult to adjust these different learners when you have no visual cues, you have no body language, and there's kind of this remoteness between you with virtual learning. Additionally, it's easier to get distracted. We get a million emails, we get a million texts. It's easier to look away when it's just a screen you're talking to instead of a group of people. Point in case technology issues can be troublesome. And then there is less of a there's more isolation between the speakers and the learners. It's less of a discussion and more of a talking at someone, taking a break and letting them talk back at you, which can be difficult at times. Dr. Boer, next slide. So one thing that we've started doing in our residency program and for a lot of group discussions virtually is establishing ground rules. I'm a big proponent of ground rules for every single discussion, but for the virtual space, some things that are particular are having participants, especially in smaller groups, keep their screens on to kind of increase some accountability, to make it feel more personable, not sharing like the entire screen so you're moving all around and things like that, and just less distracting. Having learners put their full name on the screen so we know who's engaged, who's participating, dressing appropriately, so not showing up kind of just in PJs like you rolled out of bed during didactics, being on time, and then just being respectful, not eating or drinking throughout presentations, things like that. And obviously having a facilitator to go through, monitor the chat, help with any technical difficulties is incredibly helpful. We've done this for all of our residency didactics, and it's been helpful just to have someone who is in charge of, oh, if the slides aren't uploaded, who's going to be doing that, or who needs to start the recording, things like that. But one of the caveats is, are they learning? Are our learners actually taking any of this in, or have we lost some of that educational component with the move to virtual space? So wanted to talk through a couple of different methods we can use to engage our learners and how to adapt them kind of to the virtual space. One thing I'm sure you've heard of before is the flipped classroom. So we're going to talk about it in the virtual setting with flipped screen time. There are a couple different ways to do this, and one great way is using case studies to kind of flip the script on learning and really have your learners come to you in order to push forward the knowledge building and push forward the discussion. So one way that you can do this is just the good old Socratic method. So having learners go through a case series prior to coming into a session, and then within the session, asking learners questions about the case series in order to develop their knowledge, assess their knowledge, see where they're at, see what they took out of that series. One of the difficulties with this is you really are asking learners for a lot of buy-in upfront. So they really have to go through this on their own, digest the material a little bit and come to ready to learn, which can be difficult based on the setting, or can be really wonderful. Another method you can use outside of just the Socratic method, so asking questions of the learners, is script concordance. So this is a tool, say you have a case series and you're talking about a woman who presents to the ED with abdominal pain. Here you would say, okay, learners, I have a woman who's presenting to the ED with abdominal pain. We run labs on her and we find out that her beta HCG is negative. How would this change my thoughts around if she is having an ectopic pregnancy? Would this make it more likely, much more likely, unchanged? Would it make it less likely? And going through kind of how much these different bits of data and information play into our clinical reasoning. And then the blank page is another method that you can use where you simply start with just no prepared slides, nothing like that, just a blank page, and you start writing as the learners are giving you the case or the scenario and telling you about it. And you start writing down facts and points from what they're telling you to kind of build a lecture out of what their learning is and what they've learned. And Dr. Bohr, I know you've had a little bit more exposure with that blank screen, if you had anything to add about that.
Let me go back for a second. Well, with the blank page, that's how I lecture these days. Maybe it's out of laziness, I'm not sure, but I just throw up a Microsoft Word document, blank one, and I'll start with 35-year-old para 000 LMP 121096, not 121096, 121021, let's say, comes to you complaint of abdominal pain, and then I'll just start asking questions. So it's a combination of the Socratic method and just having a blank page, and as the learners are speaking, I'm typing down the answers to the questions that they give me as I ask the questions. So for a medical student, it's very basic. I might ask them what LMP stands for, or how to ascertain what an LMP is. Is it the first day of the last period? Is it the last day of the last period? What does EDC stand for? How do you figure out somebody's EDC? And so I dissect each little part of what we're talking about to ensure complete learning. Because a lot of times I find students will just accept something without thinking about it. And I keep asking them why. It's one of the key questions I ask is why, not only to the students, but to our residents. So I've tended to start to lecture to our residents this way, is also just using a blank page. You have to be very comfortable in being able to veer off in any single direction where the learners lead you during the lecture, however. So get to feel like you don't need the crutcher slides anymore. Okay, keep going, Patrina.
So the next things that we wanted to talk about are if you're not coming from like a case series small group discussion, but you're coming from a regular lecture. So while the latter applied really well to our undergraduate medical education learners and the small group case studies that they do a lot, the regular lectures are realistically what a lot of residents see more of. So how do you check knowledge throughout? One is just during the lecture itself. So asking questions. We recently did a CREOG review where we did polling with multiple questions within. There is, some dedicated material, and then we would have a question and we would all contribute and give our answer. And one thing that was nice about this is it's anonymous, so you can answer questions or you can make it not anonymous depending on the comfort level of the group. So you can answer questions, feel open, and it forces people to participate a little bit and engage in each question, which can be really, really helpful. And it lets you check in to see in the moment, where are we splitting? Is this a question that everybody got right? Or is this something where people are really split evenly and there's room to grow and learn from this? Afterwards, so if you don't have time to incorporate questions into the lecture itself, after you can give a quiz, but it's really important to take time to actually go through that quiz and go over those questions. Make sure that you're digesting and taking everything out of it and addressing any knowledge gaps. One of the other things you can do is kind of just a minute paper where you ask these 2 questions to learners and give them 1 minute to answer. And that forced time really can help get people to put down just the first thing that comes to their mind, which is probably the thing that's going to sit with them and set, meaning the most important thing they learned and things that are unclear or confusing. So I can really help guide you. And then one thing to keep in mind is there are different ways to assess knowledge. We touched a little bit actually in the last one on this, but formative versus summative knowledge. So these lectures, a lot of times it can be helpful to think of them as more of formative knowledge. So how is this adding to, how is this adding to my learning base? How am I growing from this? This isn't, you know, a question looking at, do you know everything there is about Ob-Gyn? This isn't a CREOG question. This is really just a check-in along the way. And then one last strategy is still applies to regular lectures, but it goes to retention. So looking at immediately after asking learners to submit 3 to 5 facts that they took away from the lecture. Then 1 month later, asking them to just give you one fact that they remember from the lecture. And then maybe seeing if you could push that to 6 months, 1 year down the line. And the idea behind this isn't having the learners take notes and then read off their notes. It's really, what did they learn? What do they remember off the top of their head? Just asking them about that lecture. That's something that we have actually played around with in our residency program with this Today I Learned model, where after didactics, we would say a couple of facts. So maybe 1 to 3 facts about things that they learned. And then Dr. Bohr had tried to go through those questions and formulate quizzes based on kind of common knowledge points that the residents took away, and to use those as a way to kind of develop future tools. And I think that's something that we're still playing with and we're still working with. But we'd love to hear from all of you what your experiences have been. If you guys have any insights on things that have worked well for your learners in different settings, because this is something that is so important to check in when you're in the virtual space, because I think a lot of our learning tools have kind of been lost in this virtual space. We need to learn how to adapt them to this kind of new future with our medical education.
Yeah, and for till rounds, I thought I had stumbled onto something quite brilliant, to be honest with you. I thought I would make the learners do all the work. They would have to submit. I made up a Google Doc. I sent the residents. We did with the residency program. I sent them links. After each, we have 3 hours of lectures on Wednesdays. They would hit the link, and up would come up with, type in your facts, basically 1 per lecture, like 3 facts for the day. And they were actually doing it, but cross-checking the fact, not cross-checking, but like looking through them and trying to make questions out of them. That is where the part became extremely labor intensive. The facts weren't always that great. Sometimes they're just, I can't, sometimes just one of the residents would write, I learned a lot about endometrial cancer, which is not a fact. So I would have to like correct them basically. Sometimes they write the most simplest thing, unopposed estrogen is a risk factor for endometrial cancer, which is something I would assume they would have known from medical school. So it's the quality of the facts weren't always that great either. They did do it very religiously for about a few months, and it started to get some drop off, and fewer and fewer people were submitting them, even though I reminded them to submit them. But after 6 months, we did have about 600, 700 responses, which isn't terrible, but again, the quality of the facts, it was hard to adjudicate that wasn't always that great. And again, I thought about writing quiz questions from it, but became very difficult. So I'm trying to go back to the drawing board to figure out a different way to ensure that they're learning, but it's learning in the moment is one thing, but long-term retention is what we're really after, and that's what we're trying to accomplish here. So that's the end of our presentation. I think Petrina for our PGY2 did a wonderful job. Let me stop sharing the screen so I could finally see some people's faces. And if there are any questions or any comments, anybody want to say anything, feel free at this point. And I guess Marianne will just yank us out when she needs to. Or don't. I'm comfortable with silences.
Oh, that's one point I actually would love to bring up to the group. When I learned to facilitate peer facilitation groups, one of the things we learned was to use silence to our advantage. And in a small group setting, when you're sitting around with multiple people and everyone is silent, someone gets uncomfortable pretty quickly and will answer a question. But in a virtual setting, you can walk away from a computer, you can do a million other things. So using silence to your advantage in the same way has proven more difficult to me. And I wonder if anyone has any insight about how to do that in an effective manner, I guess.
I think the one thing that I've learned is to wait, longer than the 7 or 10 seconds that I would normally wait to fill in the blank myself. And for some of us, that's the hardest thing to do in the world. Is not just starting to talk and lecture and all that, but really giving your learners the chance to absorb the material and process it, because that takes longer in the virtual world as well, right?
I try to avoid the silences up front. I tell the students, I have all your names. I'm going to go through each and every single one of you at least 2 or 3 times. It's a round robin. I will be calling upon you. If you get the answer right, that's great. If you don't, that's great as well. We're just learning here. No one's taking any grades down. As long as you do well at the end of the clerkship, you're learning during the clerkship. I tried to make it less threatening. And I think being on video makes it easier to get the thing wrong, because you're not sitting next to somebody and they're looking at you, I guess, because people don't want to look, I guess, not intelligent in front of their peers. But I kind of force them to answer that way because I just call on them. It's all about interacting, and the interaction hopefully drives learning.
Dr. Fan says to wait until they get 2 more answers before they move on. And Dr. Mercer brings up whether we should have cameras on or off, and that there's some controversy over that, and has gone from a ardent cameras on person to an either way, and being very comfortable with that, to respect the learner's privacy and choices and comfort.
I think that's a good point to keep in mind, and also just keeping in mind that we're being as accessible. So for folks who aren't as privileged and don't have as many abilities, just making sure that everything you have is accessible. If it's possible to do subtitles on virtual presentations, things like that can be really helpful.
Since this was originally supposed to be around a round table during breakfast, and I'm looking at a square grid. One of the last questions Petrina was going to ask was like, what other people may do in their own institutions that they found semi or fully successful in terms of, besides engaging learners, trying to ensure that there might be some long-term comprehension. Obviously, repetition is the main thing, which we're trying to do with the till rounds. But I was wondering if anybody else had any other strategies. That's how weight loss works. It's spaced repetition. That's how Noom work actually works. It's spaced repetition. So they stole that from the educational literature.
I was going to share that I have returned to some of the in-classroom technologies that I used to use. So Kahoot is a huge favorite with the medical students, and we can still do some of those things in the virtual environment. So even if their cameras are off and nobody's talking, I at least know that they're there and they're engaging, and that helps me as an educator not feel like I'm just talking to this black void sometimes.
Yeah, gamification is always fun. I used to do a Jeopardy thing in person. You can still do it online though. And Allison said they don't have their cameras on because not all the students are in safe spaces. I guess maybe they're in some very private spaces to have that camera on.
I like Dr. Nenton's comment, which is more disrespectful to the speaker, whether you show up in your pajamas and your hair all messy, or whether you keep your screen blank. I agree, it's a toss-up.
I guess the camera's on philosophy is like, because people feel like it's like you were supposed to be here in person anyway. not in your pajamas. So this is like the lecturer's time, and you should, you don't have to wear a full suit, but to just dress semi-appropriately.
I have a question for you. The issue about recording material and having it available asynchronously. I've had some instructors be concerned that their intellectual property rights, for lack of a better word, might be disrespected by students who record sessions. Do you guys have any thoughts about that?
We try to explicitly leave that up to our facilitator and ask in advance if it's okay for recordings and if it's okay to hand out associated lecture material. So that's something that the facilitators really come in key to take over. Obviously, you can't stop someone from hitting your recording button during a session, but everyone can see it if that does happen. So
Yeah. And, we post the recordings, as some or all of you know. I run EFA, and we post, if anybody wants to submit lectures or post it there, it's up there for posting. There's a disclaimer that you have to sign before posting a lecture, but it started during the pandemic, so it's available to kind of level the playing field, because not every institution has a large number of speakers or faculty or experts in whatever area it was. It's just a way to democratize medical education. We tried putting a few medical student lectures up there. I don't know if medical students really know about it. The residents know about it more across the country, but we did get a lot of hits when I put up a couple of my student lectures up there. So, everyone has an open invitation to post lectures up there if they feel comfortable. There's always the worry about, you may have copied a diagram or something like that. I think as long as you annotate where it's from at the bottom, it shouldn't be an issue. We had talked to that with ACOG and CREOG about that, and they felt that was appropriate. It was okay to do it that way, and as long as people sign the disclaimer at the beginning as well. So Farida said only the program coordinator and her are given access to record. I leave it to the residents to record. The facilitator records each Wednesday. They have a designated schedule of who the resident facilitator is. So it's more from, it ends up being like, this is a lecture day run by the residents, in a sense, where the residents ensure that the lectures start on time, end on time, recorded on time, and everyone's appropriately theirs. I can't keep up with the chat.
Yeah. Dr. Valentine points out that they record one student lecture for a block and post it to a Blackboard or Canvas, I guess, and that everyone was aware that the recording was going on, and then they used it for the rest of the year. We certainly did that during the first part of the COVID epidemic, but some of our instructors have been concerned that their material might outlive them and become inaccurate or dated, was the other thing.
Well, I mean, that's just the nature of the game. It has to be updated every now and then, and not everything on YouTube is accurate, as we all know, and things get posted all the time. So you do have lectures that overwrite other lectures. And I think students intuitively know, like, an older recording is not going to be more accurate as a newer recording. And
though I do like the mention of having some sessions that aren't recording to allow for a more vulnerable space, because there definitely is a thought in your mind of, this is being recorded. If I answer this question wrong and someone watches this down the line, what will they think of me, or things like that? When you get caught up in your own thoughts, or is this going to be outdated in 20 years when someone else is watching this lecture? So having an option to not record could really free that up.
Yeah.
Yeah, and as Megan said, recording lectures allows the students to view it asynchronously as well, to re-review it. All these years of giving resident lectures, we never recorded any of the lectures. the people on nights miss them all the time. And it seems like a no-brainer to record them, so at least the people on nights can see them.
So it looks like we have about 3 minutes remaining for the session. If there are any last questions that
Yeah, some faculty don't want to record lectures. I'm not sure why. It's not like they're going to perseverate and think about it. I just forget about it. I mean, if it's recorded or not, I don't even remember. You just move on with your day, basically. This may be recorded for all I know. I don't even know. Maybe Marianne is recording it. I'm not sure, but I won't remember it tomorrow. Oh, and by the way, the PowerPoint, and I'm sure the first groups, I don't know if they had uploaded it, certainly will be, I think we can upload it later, right, Marianne?
Yes, you can, and I'll go ahead and stop the recording now.